better sleep, sharper focus, a healthier life? It all starts with how you breathe.
Welcome to the No One Told Me, the Airway Health Connection, the Untethered Way, where better breathing meets better living. I'm Dr. Meggie Graham.
I'm Dr. Liz Turner.
We're the co-founders of Untethered Airway Health Center,
on a mission to help you breathe freely and live fully through proactive airway health.
Whether you're a dentist expanding your airway expertise
or a family looking to sleep and breathe easier,
you're in the right place.
Each week, we'll bring you bold insights, real-world stories, and expert tips.
All to help you take control of your airway health. Because when you breathe better, you live better. Let's get started. I am so excited to be here today with my friend and colleague, Tracy Tran. She is a pediatric dentist in California and also airway-minded, and does all things from the perspective of ideal growth and development. Tracy, welcome to Nobody. No one told me. I always want to say nobody told me. No one told me. Our podcast about kind of connecting the dots while looking backwards. So welcome. Tell me a little bit about how you got into this and tell me your story. We love stories, right?
Yeah, stories are great. I got into this from an OT friend who I met at a barbecue and was like, "You're a pediatric dentist, you do tongue tie releases, you should do it. You could totally help these kids with ADHD and grinding their teeth." And I'm like, what? This is like wild to me. Like, how do you even come up with that? But I was curious because there were so many kids in practice that were like getting, that were on medication for ADHD. A lot of kids who would grind their teeth like profusely. I would see like significant wear. But like what we learned in dental school and residency was, oh, they'll grow out of it. So I know that's kind of like a cop-out answer,
When
right?
was this? Was this before you had your own kids, like early on in your career?
Oh yeah, this is back in like 2016, I want to say. So
yeah.
No kids, no nothing. I was maybe like 2 years out of residency. And so I looked into it and she like kind of guided me to take a course with the Academy of Orofacial Myofunctional Therapy. And they had like a frenulum inspection workshop. And actually Zagi was like giving a lecture for that. So this is like pre-Breathe Institute. And I'm like listening to him talk and he brings up the study with him and Audrey Yoon. And I was like pretty fascinated by all of it because I'm like, oh, okay, this makes sense. It's from the breathing perspective and like functional breathing perspective, not so much like
just the tethered oral tissues.
You got a tongue tie, so now you've got ADHD.
Right. You're like you're connecting those dots.
The dots were being connected. So I'm like, okay, this I can get on board with. And, they always have a lot of people. Back then it was, I guess this was the time when it was becoming really popular or trendy, people would say. And, but I'm not like a trend follower. I wasn't necessarily trying to follow a trend. I was more so looking for answers because I'm hearing their stories of how people had their tongue tie releases and so many things changed for them. And then I would hear other stories of people getting tongue tie releases and nothing helped. So it was like, okay, what helped? What doesn't? Why is it helping some people and not the other? Like, what are the nuances that aren't really being spoken about? Because you get like the extreme people who are saying everyone needs to get a tongue tie release. And then you get the other people who are like, nobody should get a tongue tie release. And there's got to be a middle ground here. So I kind of spent the early part of my career in this space trying to sift through and asking questions of, okay, what's reasonable? What's not reasonable? Where's the middle ground? Why are these patients experiencing improvement? Why are these patients not? And through that journey, just figuring out, okay, how can I help people and get predictably good outcomes? It's always been like my approach to all this. Like, how do you predict that you will actually get improvement? Because, the last thing I want is for a patient to come to me. And I was seeing this. They would go to providers who would do releases and get no improvement and go and tell the pediatricians who would then say, they're the ones, it didn't help. And so they're usually the ones who are like, tongue tie's a fad, it's not a real thing. But then and when I started doing it and it was helping families, I'm like, okay, so it clearly does help. What's the missing piece? So that's where I landed on, kind of like the myofunctional therapy, understanding functional things with the older kids and getting better outcomes and healing, and how that translated to babies. So I actually didn't start treating babies right away. That was more like, oh, okay, developmentally, there's things that this can impact. So let's
Go further
let's
back.
let's try to help them a lot sooner and see if we can help.
Yeah, it's interesting how, like, I always say we're structuralists, right? We're trained to look at teeth and cavities and maybe a little bit of soft tissue and the bone around the teeth, but like we're very structurally trained. And then to then identify tongue ties or restricted tongue movement as a problem, it's in a vacuum. It's not looking at how does it impact the function? How does it impact growth? How does it impact the airway? And so I agree with you what you say about like the pediatricians. I think that they see a lot of, at best, neutral results or even some negative results because the provider, who's hopefully very well-meaning, just didn't zoom out far enough to connect the dots and understand, where does this fit into the global picture of the patient?
Right.
Yeah.
Right. And it's sad when that happens, because then here on one end, you get people like the dentists who can see it and understand the mouth and function. And then you get the pediatricians who are like, and not to like put them in a box and say all pediatricians are like this, because I actually learned from a pediatrician early on in my career how to do tongue tie releases for infants. But it's more just, it made sense to me from the social, societal, clinical standpoint. What they're being exposed to and what we're being exposed to is very different. So, and when I understood that, that's when I was like, okay, this is how we need to tackle getting the word out there, not by saying that pediatricians don't know what they're doing,
Oh, they just have
but by
such
saying,
broad scope.
yeah. When I would see, and you've probably encountered this, like everybody, I've seen like some people in this space be like, don't talk to pediatricians, just like when it comes to expansion, don't talk to orthodontists. But it's like, I don't think it's true that any profession isn't open to it. I think it's just a lack of knowledge and time. Like, do they have time to go learn these things too?
Well, also, do they have time to go learn it? And implementation and changing the way you've done things and the way your office workflow is challenging. So like, even if you get there conceptually and you get there academically and you understand, then to go home and implement it and change your flow is really hard.
It is. It's really hard. And for that reason, like I kind of saw that really early on in my career. And that's when I was like, okay, if I'm going to do this, I think I really need to just focus on this. I don't think, as I was learning how to do a consult, how I wanted to set up my consult, how I really wanted to spend a lot of time educating patients, I realized if I'm really going to get good outcomes or even just get patients on board, I have to put the time into it with them from the get-go,
Right.
which actually doesn't work in a traditional pediatric dental workflow.
It's really fast paced, right?
It's so fast paced. And so I was doing this in my colleagues' offices. And so all these pediatric dentists are hearing about tongue tie and, airway stuff. And they're like, we want to implement this. Can you come do this in my practice? So there's one of my colleagues, I did it for her up in LA. And she just straight up told me, she took insurance. She's like, we only got reimbursed like $100 for this, and you spent so much time for this with this patient. She's like, you can't do this here. We're gonna have to you're gonna have to do this separate. And I was like, okay, that makes sense from the business standpoint though. And she's like, as much as I want to implement this into my practice, she now is like, she doesn't want to do it.
Business model.
It's yeah. So I created a whole business model around being the resource in my community. And I decided not to do dentistry so that nobody would feel like I was competing with them.
Yep.
And so just by doing it this way and seeing how much I had to learn to get comfortable treating and feeling like I could get predictable outcomes, it's like anybody else who wants to do this, that's the time that you have to put into it, the experiences you have to have until you get comfortable with it. It's not an easy feat. And so in a sense, I look at it as its own like subspecialty, even though it's not like a true specialty in dentistry, right? But
your yeah, it's not a true specialty, but they're very specialized procedures. And I don't think that, at least the way we're trained or people understand it, do they realize how nuanced it is, how interconnected it is, and how much education and conversation needs to go into it if you're going to do it well. Liz and I will always say, like, we don't do clip and goes, right? Because first of all, you're going to miss pertinent anatomy. You're going after structure that you don't fully understand if you're clipping a tongue tie. And
Yeah.
we know that that outcome is going to be poor. And so
Right.
to understand the complexity of the tissue, the anatomy, the diagnosis, and the function takes a lot of time. And it's not in everybody's wheelhouse nor desire to do it.
Right.
I do think that there is a need, an absolute need because of an access to care for people like you that aren't specialists that specialize in these procedures.
Right. And also just like the education in it, like how much would you say you spent in education to learn all this?
Well, we talk about this all the time, right? You come out of dental school, hundreds of $1,000s of
Yeah.
debt, and you really don't know enough to treat. And then
Yeah.
to really learn and to go on and become skilled at something. I mean, I think our state requires 30 hours of CE every 2 years to maintain your license. I mean,
Right.
I'm sure that both of us get over 100 CE hours
Yes.
a year, spend hundreds of thousands of dollars on CE to
Yes.
be as good as we can be.
Yeah. And I see that from my colleagues when I'm like, go and learn it, go and learn it. If you want to do this, like, and implement it, go and learn it. And they just, a lot of them, it's hard for them to swallow taking a course for $5,000, $6,000 when they're not sure if they even want to implement it into their practice. They don't have enough knowledge around it. And then you get other dentists who are like, they're willing to put the money in and the time in, but then afterwards they're like, that was so dense and convoluted in information. I couldn't capture everything. I'd have to take, they realize how much more they have to learn and take to do it. And they're like, I don't want to do this.
Well, you taught and teach, but you taught a frenectomy course for a while. Um, you have kids of your own. Liz and I teach our own frenectomy course. We're moms. Do you think on a Venn diagram that the overlap of people that want to implement it are parents or moms that have seen it firsthand on their kids? Because
Yeah.
that's what I'm seeing.
Yeah. Most of it is people who try to find help, dentists that wanted help and they couldn't get it. And then now they see the impact that it made when they did get the help, that they want to provide and have that impact on somebody else's life. Because that is the most rewarding thing in what we do, right? It's, I will say, I feel so much more like I'm making such a significant difference in my patients' lives doing what I'm doing now than I did doing fillings.
Tell the audience or whoever was listening, like, what do you do? So what does it mean you don't do pediatric dentistry anymore? What do you do? What services do you offer?
So I'm more of like a functional dentist. I always say like when it comes to function in the mouth, there's like four basic things, right? There's feeding and swallowing or suck and swallow really early on, chewing. So things that you do around feeding. And then the other thing is speech. That's what you do with the mouth is you talk with it. Um, and then what does the mouth aid in? Growth and development of the jaw. And then the other thing is going to be with breathing. So if your tongue is not in the right place or your jaw's not developing, breathing's going to be impacted, and that can in turn impact sleep. So that's where the whole airway thing comes from. But it's funny because I don't like to say that I'm an airway dentist, but it seems to be the buzzword out there. So I use it, but
I say airway-focused dentist.
yeah, but I'm
And
more like functional. I
yeah,
look at function and at what point in their development is the function going to seem off, or when is it developing? When can we intervene to give them the most optimal development in their function so that the jaw and the face can grow optimally as well? And since so much development happens before the age of 6, they're already like 70-80%
right.
developed
Yeah.
by 6. That my focus has always been on treating kids before the age of 6
Yeah.
and really understanding functional development, like what milestones are they supposed to learn with their mouth, like when did they start feeding, obviously breastfeeding or bottle feeding at birth, and then when does the suck reflex integrate, and then when do they start solids, and then when do they start babbling and talking, and when does speech really develop and start to blossom, and then how is breathing impacting sleep and brain development? All of this happens. The timeline is all in line with each other with all four of those things.
Yeah.
So once I understood that, I'm like, okay, so this is what I do is I look at what's happening developmentally, how it's being negatively impacted, educating parents on how this will essentially impact their growth and development. And if they want to optimize on it, that's something I can help them with. And so, and it's the symptoms that we hear all the time, right? They're grinding their teeth, they're not sleeping well, they're not feeding well, for the infants is the common thing.
Yeah.
And then for an older kid or a toddler, having a difficult time with solids, speech is off with their articulation. And sometimes they don't recognize speech articulation as an issue until they're like 5 or 6 years old. And they're like, oh, okay, we thought it was cute, but they still have a problem. So then maybe fix it. But even as a toddler, sometimes they're delayed in speech. So I do everything involved to help treat those issues
Early
and
on, and
early
then
on.
you refer out to have cavities fixed. So hopefully by addressing the functional issues, they're lower risk for cavities. And you're
Right.
saying that like that, this role in the functional side of growth and development is way more rewarding than traditional pediatric dentistry was when you were putting out fires.
Right.
Yeah.
So doing the fillings, you're putting out fires, but doing what we do now, getting them to nasal breathe and not mouth breathe, helping with, it goes beyond that for me too, though. Because sometimes the symptoms that they experience might not be because of a tongue tie.
Right.
It could be, or the sleep issue might not be because their mouth is too small. It's compounding the problem, but it's not the root cause.
Mm.
So I would say that's the other thing I do is I'm more like a root cause dentist because reflux is a huge thing that I see in infants, and that's a problem. And that could be a microbiome issue, some GI thing, which normally one of the parents have an issue, or the sleep stuff could be they have allergies, so their adenoids are enlarged and they don't know what those allergies are, or food sensitivities that are creating it, or the reflux is causing, the airway tissue to get enlarged. So I, for me, in order to treat this well, and here's the other reason why I did this, I wanted to help parents find the path of least resistance that would be the most effective.
Oh, I love that.
So,
Yeah.
because they would go get a tongue tie release and then come to me and be like, oh, they need expansion too. And if they would have just come to me, I would have found all of it and would have said, this is the best order to do it in. And
Right.
we do it one thing at a time because every parent will say, this is so overwhelming. There's so much to do. So from the business side, my practice is also set up to help the parents step by step as we're collaborating with other providers. So it's just, we give such a full plan that's so comprehensive that you could go to a dentist or anybody who's learned, about tongue tie releases, but that's what they've learned is just tongue tie releases. They haven't learned the airway component to it yet.
You really need, I mean, it's such a journey. And I tell parents that all the time that it is a journey. It's okay to take breaks. It's really important that you and your child don't get burned out.
Right.
And it doesn't have to be fixed overnight. It didn't start
Yeah.
overnight. So having that relationship and that trust and being able to be their quarterback or that guide through the journey is such a gift.
Right.
And you think about speech pathology, or you think about GI and acid, or you think about sleep. Each one of these things are specialties. Airway is not a specialty, but each one of these are specialties. And each provider that treats, physical therapy treats torticollis, GI teaches treats reflux, OT treats body issues, speech teaches speech. But if you're not connecting the dots, you're like literally spitting at all these tiny little fires and you're not getting to the root cause. And so to be able to step back really does fall into the pediatric dentist's hands or the general dentists that are
Yeah.
children, because pediatricians don't have this training. Physical therapists are limited with what they know. Speech therapists are limited with what they know. So it really does become
Yeah.
your responsibility.
Right. And if you tell them, hey, go do this and this should help and it doesn't, then it's only going to upset the parents. And it's so much work to do therapy too, on top of that. So much work to treat the tongue tie and do the aftercare. Um, I always want to make sure that what I'm doing is going to be fruitful for them, that I'm not just speaking, excuse my language, out of my ass and saying, hey, do this and it's going to help.
Right. It's a we as humans are multifactorial. We're a huge puzzle. I
Yeah.
can tell you looking at you, you're not you, but the patient, Your
Right.
structure is off, your function is off. Let's fix these things. It is probably not the only piece of your puzzle, but let's address what we can and kind of keep going in an order that makes sense, that's the most efficient, avoids burnout. I'm watching actually an adult patient right now is close to me, and his structure is all wrong. Like he's a double jaw surgery candidate. His function is all wrong. He's looking
Mhm.
into having the Inspire pacemaker for his tongue. He's looking into GI surgery
Yeah.
to lose weight.
Oh my
And
gosh. Mhm.
he desperately wants a fix. And it's not to say that there's not a place for these other modalities, but if the structure is wrong, those other modalities can't be as effective.
Right. So they
Um,
all kind of have to be done at the same time because one
or at
thing
least
supports the.
understand the order that makes the most sense.
Yeah. It's something that I really respect about you and Liz because you treat adults too. And I could not do that.
Well,
I
that's
think
our
that's,
passion for getting into kids, right? Because like
yeah.
we love treating adults and helping the suffering end, and we're
Yeah.
both airway patients, and so we can really speak to how much better we feel on the other side. But gosh, if we could avoid that from the get-go or limit it,
Yeah.
that would be even better. For people that are listening, where can they find you? I mean, you have an amazing Instagram um presence. You're so educational. Tell me about your practice. Tell me about your Instagram, because if you're listening, go do yourself a favor and go follow her. If you're in her area, go take your kids to her. She's amazing.
Oh, thank you.
Yeah.
Um, I'm in Newport Beach. I work every day. I'm actually in the process of having to expand. I have to move my office. The building I'm in is getting torn down. So, so I have to move. I'm getting kicked out and I'm building out a whole nother space. And um, I guess like when I started doing this on my own journey, I wanted to educate and kind of sift through all the nuances that I felt were so confusing and that I hear from a lot of parents can be confusing. So I'm just trying to like make things less confusing for everyone, not just parents, but providers too. Like, okay, where you're going to take all these different courses from different people who, because it's not like a real specialty and there really isn't a standard of care out there, like who do you know you should listen to and not listen to? Like, and what pieces of information could, maybe sounds like it's right, but might not be correct. And, like getting down to the nitty gritty with understanding development, I think really helps because then you're like, okay, this makes sense. If we can take this information and apply it to real life, then the treatment plan that we're choosing to do does make
What would be
sense.
like a red flag that a patient would hear from somebody that might kind of grasp it but not have a full comprehensive understanding of airway development or how to treat dysfunction?
Yeah, I think the biggest thing is what I hear the most is, hey, just fix the breathing and the oral rest posture and everything will be good. And unfortunately, I think and I'm always talking about soft appliances on my my Instagram, and it's not like I have a problem with them. They work. But I think there's also like a place where, like if you're using a soft appliance on a child who's
Like what,
above the age
like
of
what,
3.
when you say a soft appliance for listeners, you're talking about like a prefabricated kind of like soft mouth guard, right?
Yeah.
Okay.
Yeah. Yeah. There's companies that make it. They're like flimsy and you put it in their mouth. They have to wear it for about, like, they say 2 hours a day throughout the day. And in addition, wearing it throughout the night, which is really hard to do. They're kind of bulky and you have to get your lips closed. So getting your child to get their lips closed around this like mouth guard, it's really hard to do. Just to get them to wear it is hard to do too for like a 3 or 4 year old. So in a sense, it's not like, to me as a mom, it's not worth the time because the outcomes that you'll get from it could be great, but if they've got other underlying things that get missed, then it's not going to be a great outcome. It's not going to work. And one of those underlying things is whether or not they can breathe through their nose. Like that's such a simple thing. And I think a lot of parents and providers who are just getting into airway kind of miss. Like, yeah, they hear, let's do the soft appliance. And then they try and they're like, oh, it didn't really work. And after going through everything you and I have been through educationally, we want to save other providers from, spending money where it might not be as fruitful
And
for them.
families too, right? How many
Yeah.
families you get that came in that bought a tooth pillow appliance or
Yes.
went down the Myobrace appliance and they had or a HealthyStart. There's so many different ones out there.
Yeah.
That didn't have the option or didn't know that there were alternative ways to do maxillary expansion. And they come in and they need more than any of these devices could do, right?
Yeah.
But now they're burnt out, they're frustrated, they spent money, and
Yeah.
it's just that they didn't have the path to do it, right?
So that's like the nuance that I want them all to know is that if your child's like 70% developed by 3 years old, then the skeletal growth discrepancy already exists. So doing a soft appliance isn't going to change that growth discrepancy. It's going to help the function and it might tip the teeth out.
Yeah.
And by creating space, you can create space doing that, but it's not the same thing as actually, growing the suture and opening, here, my little model, opening this up here in the center.
Yeah.
If you can't get this to widen out,
So you can
then
make more space by tipping teeth, but you're not changing the skeletal floor of the nose, roof of the mouth. Exactly.
Yeah. And by expanding there and you get the floor of the nose open, you're helping them breathe better with nasal breathing. Now their nasal airway is more patent and airflow is resistance is decreased. So then the airflow can flow a lot easier through the nose. So nasal breathing essentially is easier for the child.
And inflammation goes down and reflux can go down and grinding goes down.
Yeah.
Yeah.
So I think that's like probably one of the biggest things.
Is that there's not a magic bullet.
It can be misleading and puts these patients and families and providers alike in a boat where I had a mom reach out to me on Instagram when I was talking about this. And she was like, I got the tooth pillow, it didn't work, but it was the dentist who recommended it. And she was like, what should I do? Because one of the things I brought up was, if it didn't work for you, you should ask for your money back. So a lot of parents then were like, what should I say to get my money back? And, and I had a conversation with Tooth Pillow actually last week and was it earlier this week? No, it was last week, last Monday. And they were asking me questions and I'm like, well, here's the deal. Like, you guys are providing a product for people's health. And if you're going to recommend a product, you really need to dive deep into their medical history. I don't see how it's possible for one doctor to review 50 to 100 cases in a day. And yeah, it's what they told me. Which is a number they're very proud of.
One doctor?
One doctor's reviewing it. And I said to them,
think about how long it takes you to treatment plan a case.
It takes
how long I spend looking at photos and x-rays and
I spend a full hour with one patient. We get CT scan, we get
and their health history, and there's my God, 50 to 100?
50 to 100.
How many minutes are there in a day?
I'm like, so like to dial that in as a provider, what I know is if you're going to go through that many cases and you don't even have any imaging besides photos to go by, of course, almost every child out there has dental crowding. So you're basically looking at dental crowding and saying, yes, this child has dental crowding. They're a candidate for this appliance. And by doing so, I'm like, well, there's your problem. Your one provider cannot possibly review medical history and find out. And you guys probably don't even have the question on your questionnaire of whether or not they can nasal breathe.
In 24 hours, there are 1,440 minutes. Mm-hmm. That's in 24 hours. Like, that just seems like that's impossible. Like, that's insanity. That's just like clicking yes.
Right. So,
wow.
I'm supposed to have another meeting with them because they were like, well, maybe we can consult with you and you can help us like be better with our screening practices. Because when they met with me, they were just like, we want you to be able to still speak your truth and everything. I'm like, that's great. I want you guys to understand, for me, what it comes down to is I care most about the families. I care most about them not wasting their time. And I really believe that you guys are well-intended. I don't think there's any malintention here, but I do believe that you guys have a responsibility to improve your screening practices. And so what they told me is they approve 1%, children under 7. Only 1% of them get denied, but children over 7, they deny 50% of the cases. And so I did say to them, like, but wait a minute, by 7 years old, they're like 70 to 80% developed, maybe even 90% developed. that doesn't make sense to me. The discrepancy already exists. So really you should be denying more cases under 7, not just 1%. And I'm like, and so,
Or to
and
be using it as an adjunct to other therapies. It's just that it's like the over
yeah,
promising and under delivering that's problematic. Like, this is all you need, this will work.
yeah.
Okay. It's just the transparency piece that I
Lack
think
of
is so essential that parents have, that this is what this can do, this is the limitations.
right.
The
And
end.
I can tell them that because I guarantee you, every parent for a 3-year-old, when I'm like, well, let's try Myobrace if you'd like. And then when I tell them what's involved in doing it to like have predictable outcomes, how often they have to wear, they're like, there's no way. There's no way I can get my
Brushing their teeth
3-year-old.
twice a day is hard.
It's already really hard. They're like, there's no way I can get them to wear this in their mouth. So when they have patients who do it and they show pictures of like before and after, and we see the teeth look straighter, like, of course you can tip the teeth and rotate them and you can get them looking straight. And, that's the same argument I have with orthodontists too, when they're like, well, we can still straighten their teeth. We don't have to expand. I'm like, but
It's not just about the teeth,
it's
right?
not.
Not just about the teeth. It's about the whole picture. And we say we can influence the jawbone, but you think about the upper jaw, like that's the entirety of the middle face.
This is like, yeah, it's the growth center of the
Bring up your
face.
bring up your skeleton again and just show what the upper
Yeah.
jaw is.
So
It's that
this is
whole
the
pink
growth
thing.
center.
It goes all the way up to the bridge of your nose. It's your cheekbones. It holds all your teeth. It's the roof of your mouth, the
Yeah.
front of your nose. That all is the
Makes up
jawbone.
the orbits,
Yeah, it's such a
all
big
of it.
space that we're influencing by changing
So,
growth. If you're putting something that can just tip teeth, we're missing the opportunity to influence that bone.
yeah. So I always tell parents, like, look, this is your bone. And this is even for like my orthodontist friends when I talk to them. I said, one of the biggest things, and I'm like, and I think this is why we get a lot of general dentists who now want to get on board with airway, is because what orthodontists don't see is the long-term effects
Right.
of not having enough bone structure. And it's a periodontal issue, right? So what's the
Or
periodontal issue?
the failed restorative work over and over again. Yeah.
Right, because of the dysfunction. So you get one or
The bone.
either or both. So I always say to orthodontists, well, you got to think of a bone, and this is how I explain it to parents. The bone is like a garden, and the teeth are like flowers. So you can get the flowers to fit in a small garden, and you can plant them that way. But then when they grow through, they're going to come in different directions because they're going to find their way in. But if you look at the roots, they're all kind of like tied together. They're all close together, even though the flowers kind of came out. The teeth are the same way. If we make the garden bigger, we can space out the flowers more and line them up perfectly.
Oh my
And
God, that is a beautiful analogy. I
each
love
of
that
the
one.
roots have good soil to surround them, and they're more solid in the bone. And that's what we want. We want to make the bone, the garden, bigger
Oh, it's so
so
beautiful.
that all of the teeth have enough bone to surround them. So forget airway for a moment. Forget airway. This is about creating a more healthy dental situation in the long term for our adult patients who, buccal bone, labial bone is where most gum grafting has to happen. Bone and gum grafting has to happen. Like here, the lower jaw in the anterior. This is the hardest place for most people to deal with. And then if you have small bone and the orthodontist straightens your teeth, they have to tip the roots in different directions to make that work. And my husband's a general dentist, so we have this conversation all the time. He's like, there's so many times where I want to place the implant, but the bone's been impacted or the roots are tipped in a weird direction that doesn't give me enough space to do it because of the work that the orthodontist did. And the orthodontist straightened the teeth, they did their job,
The
but
teeth
they're
look
not realizing
yes.
it looks pretty from the outside, but underneath what we see, what dentists look at is we know what the bone structure is and whether or not there's enough space. So, you go back to something like doing a soft appliance, it's the same thing in these kids. You're tipping the teeth out. You didn't grow the bone, and now we've got an issue. In the long term, you're not helping them. And you took up a very critical time in their development when we can get the most bone growth if we do expansion early on.
Yeah.
And when we start expansion at 4, Mariana Evans talks about this. Like, this is what she teaches. And have you taken her course yet?
I've seen her talk a lot. It's just
Really,
great. She's amazing.
it's really good. So that's what she talks about. She's like, if you start at 4 years old with expansion and you grow the bone, those dental follicles that are way up there will erupt in a more ideal position and it will bring better bone with it. And so from the periodontal perspective, you will have
Exactly.
better looking bone and teeth. So,
And when we were in school and in residency and, orthodontic training traditionally is you don't expand until at the very least, the 6-year molars are in. But there's been amazing research that shows if you expand in the primary dentition, you don't impact the periodontal health of the permanent teeth because you're letting them grow solid and bone. And that's exactly what you're saying. That's so important.
it's a huge deal. So the work that we do by doing such early intervention the right way isn't just about the airway and the breathing. It's such a big part of the dental health, such a big part of the mouth function. I mean, what are the major issues you deal with adults that's the most complicated to treat is TMJ problems, right? Like when they're in dysfunction, their TMJ is impacted, and how do you help that? How do you fix it? It's so complex.
And
And it's one of the hardest things to get good outcome in the long term.
I watched I try really hard to stay off of social media because I can just go down negative rabbit holes. But I was watching this comment exchange, this angry comment exchange just about a generalization that early intervention for correcting the airway in a population in the primary dentition is a money grab by pediatric dentists or general dentists that are and it's like, hey, I can't think of right? A harder population to treat. Like that's challenging. Why would you put your child through something like this? Well, as a general dentist that's, has treated patients through a lifetime, the interventions don't get less involved. They don't get easier on the patient, and they certainly don't get less expensive, right? So if you put this, and kids are resilient when you treat them this young, they really can tolerate it. It's something you have to invest in. I'm not saying that the journey is not hard, but looking backwards, it's significantly easier than a lifetime of putting out fires or dealing with pain or jaw pain or poor sleep or failing dental work and having to continually go through things.
Yeah, and say we don't do it perfect, we're at least decreasing this discrepancy that develops over time.
Yeah.
Like if you do nothing, that discrepancy stays where it's at. It gets worse because as growth is supposed to happen, it's not happening. But if we intervene, even if we're intervening a little bit, even with orthodontists too, and traditionally, one round of expansion can do a lot for a kid.
And for anyone that's listening that has kids that are older than 6, you're not too late. We're talking from an ideal perspective. It is so great if we can treat somebody that has breathing dysfunction or suboptimal growth. If we can treat them at 3, 4, or 5, fantastic. If your child is 6, 7, 16, 17, and we recognize that they grew dysfunctionally, have that awareness so that we can treat them appropriately now and don't just deal with the tiny little flower bed and the teeth or the flowers that are on the wrong spot. We can still treat them that age. We just need to now do it in a different way than we would have when they were younger. But it's not that you can't fix it later. You just have different tools to do it later.
Yeah. So the growth is different, and the way that the bone connects is different as they get older. That's all. And then the teeth you have to anchor to are not as strong because the roots are more resorbed. So that's why we talk about treating at like 4 or 5 years old. Even in the primary dentition, those teeth roots are much more stable to anchor on with an expander than in an 8, 9-year-old or 9, 10-year-old whose 6-year molar roots aren't fully developed yet, and their primary molars are now all the roots are resorbed, so you don't have great anchorage. So
as a baby tooth comes out of the mouth, like a grown-up tooth ideally grows up underneath it. And as it grows up underneath it, the root goes away. And then when a kid loses a tooth, it's just the top of the tooth and the root is gone. So what Tracy's talking about is like, if you expand when the patient's younger, they still have solid root in the bone. The other thing with your little skeleton that I think is, I'll show parents with my fingers like this a lot, like when kids are little, the bone in the middle of the mouth, the floor
it's straight and open like this.
It's easy to pull it apart, but as we age, it gets more and more interdigitated.
Yeah, like this.
Yes, and it can be pulled apart, but it needs more than just putting pressure on the teeth. We need to do something in the bone now to like be able to create enough force to pull it apart.
Yeah, it's physics. Once you get that interdigitation, there's more surface area of of ligaments connecting. So it makes it harder to pull apart.
Yeah.
So it's totally true. And that's why treating at four, the 4-year-olds, 4 or 5-year-olds, they do so much better than the 8, 9-year-olds. The 8, 9-year-olds complain of pain and discomfort with the expander more than the 4 or 5-year-olds do. And also removing the expander because we're replacing it on the baby teeth. When you remove them, those teeth are loose. So it's going to be more painful for them. Or sometimes I have to numb them
Yeah.
because the baby tooth might get pulled out when we
I
take
would
out
say
the
sometimes the teeth come out.
yeah. So it's just, we try to get as much anchorage as possible because we're trying to move bone. It's really hard to do with when you don't have enough anchorage. So then as they get older, what's the next step, which you do for adults, and that's like doing something like a custom Marpy or MSE where they have to do TADs to place directly into the
Or they're
palate.
surgical candidates and they really would benefit from jaw surgery, you know?
Yeah.
Um,
So
yeah, go ahead, sorry.
no, go ahead.
I was just gonna say, if in the little bit of time that we have left, I would be so curious to know like how your perspective shifted. You told us a story about how you changed when you were exposed to tongue ties with the occupational therapist and you started to connect dots as to how that impacted breathing and growth. Has anything shifted for you in the perspective of being a provider post children? You've got small kids at home. Has anything shifted there?
I would say maybe after I had my kids, like when they were babies and I did their tongue tie releases, I used to be really hard set on like, you need to do therapy before we do a tongue tie release. You need to do therapy. But I would say I've shifted more towards let's just get the release done as soon as possible. So if they're like a newborn, I do it and you still need the body work and you still need the therapy. But if the structure is definitely impacted, like get it out of the way so that the function can develop and grow and they don't develop compensations
There's less
because
muscle memory.
right. And they have the reflex before 8 to 12 weeks to help them with that development. After that, it's harder to do. They're more likely to need therapy. Um, but I say that because I used to be such a stickler for, the baby because they learned, they were tied in utero and they might be weak. Well, it's not that we don't treat that muscle weakness. We're aware of it, but I still would rather do the release right away in most instances. There are some instances where I wouldn't, like the suck is so discoordinated. I'm not sure if they're going to do well even with the release. But I'd rather get that out of the way right away. And plus, post-op care is a lot easier to do when they're really little. I mean, it hurts your heart, and I understand that part now. I would say my aftercare protocol is a lot more lax and flexible. There's more things that I pay attention to instead in the follow-ups, and I kind of cater the aftercare protocol based on where they are in their wound healing. So it's not like a cookie cutter. Nothing I do is really cookie cutter in that sense. I have like a general protocol, but it definitely changes based on their wound healing or the parent's ability to do the aftercare. Um, but I really believe that treating things as early as possible to give them the most development is going to be the most impactful for them. And I think for some, like the way I used to do things, yeah, my kids, I have such a better sense and understanding of how hard the aftercare can be that
Yeah.
I try to make it as easy as possible for the parents.
Yeah.
I can get in the mouth easily, right? Like we're dentists, we can do it, no problem. But I've even had dentists bring their babies to me, and even they're terrible at the aftercare, because they're
It's
not familiar with with a baby's mouth. It's so different than a child and an adult.
It's really
So,
hard. I mean, it's also hard when it's your own kid, like to look at them objectively and diagnose objectively.
mhm.
It does bring you a little, at least it did for me as well, bring an element of compassion and understanding that I didn't have before to families. Not that I wasn't empathetic or kind, but it brought a different level to it because now I was like, oh, I recognize how hard this journey can be.
I became more direct, I think, as a provider.
Okay,
I
tell
think
me
I
more about
used
that.
to be like, okay, let's really care for be understanding of mom's emotions and all of that. And I think for me, it was such an emotional decision. So my son I did when he was 3 days postpartum or 3 days old. My daughter I waited. And it was more of an emotional decision for me And I wish I had somebody else to tell me, just do it, it'll be fine. You know, even if she struggles with something, we'll intervene. We have the resources to do that. You don't like, don't wait, just do the procedure right away. Because I went through body work and all that, and I gave it about 5 weeks when I did her tongue tie release, 5.5 weeks. But then what finally got me to do it was I was up every hour feeding her throughout the night. And I'm like, she's clearly inefficient. I didn't want to do the procedure. I was trying to avoid it by doing body work and oral motor therapy. But at the end of the day, the only thing that was really going to help her do her best was if I did her tongue tie release. And so now when parents are teetering, I'm just way more direct. I'm like, look, if it were my child, I would do it. And it's not to say that like they have to do it or anything. I'm not forceful, but I'm more direct about it. Like, this is what's going on. I would get it done sooner than later. And I know what it feels like to be in your shoes as a mother. This is a very emotional decision to make. And when my provider wavers back and forth and wants me to make the decision, I'm always going to make the decision that's going to be the most emotionally easy for me.
Yeah.
And so what I want is a provider who's confident in themselves and can tell me this is what you need to do so that I can just move forward and do it versus,
Hemming and hawing and yeah.
yeah. Yeah. So I would say that's how I've changed is, yeah, I'm not as, I don't want to say not, I'm not as wishy-washy. Yeah, I'm not with anything, even expansion. I was this past week. I just put Landon's expander in
Oh my gosh,
last Friday.
congrats. That's a huge rite of passage.
Yeah, and so he's turning 3 soon, and he's been sweating in his sleep every night. He won't have a blanket over him. He's mouth breathing. He's like heavy breathing. He wakes up every night in the middle of the night. Once in a while, he's got night terrors. Once in a while, he's got a wet diaper. Usually, they're dry by the time he wakes up. But then, I'm just going to do it. I'm just going to start now. And when he's sick, he has a hard time clearing the congestion. So we did it, we delivered it, and I always do an upper and lower at the same time for every kid almost. And it's because I just want to get maximum expansion with the in the palate. So I placed the upper expander and he gagged a little bit during the appointment. I'm like, oh, maybe we just wait on the lower. And I still put that off. And then at the end of the day, I'm like thinking at home when I like could separate myself and be objective. I'm like, it would have been so much easier for me, for him even, if we would have just done it all at once. Because psychologically,
Now he's got to come back and do it again. Yeah.
so we did. We brought him back yesterday or 2 days ago, and it was awful. He did so terrible. He fought it. He cried.
Well, he's on guard now, right?
Yeah, he knew what to expect. And the biggest thing is he just hated the taste of the cement. Like that's what made him gag was the taste of the cement. Because we tried the expander in, no problem. Like he didn't gag with that. I took it home. I let him put it in his own mouth and hold on to it. So he's got good oral control, but then it was the taste. He couldn't handle it. And so once he experienced that, he was already anticipating when I told him, we're going to put your lower expander in. He's like, I don't want to do it. He like knew.
Oh,
So
sweet baby.
if
I mean,
I
how
would
cute are
have
those expanders? Or I got one yesterday. It was for a 3-year-old, and it's like my thumb can just like fit over the whole thing. It's so tiny.
Aw. But it's easier when you go through that. If I would have had, say, you do it for my child, you could have told me, just do it, get it done.
So much easier when you're not the mom.
Yeah. Versus myself trying to tell myself, do it, get it done, where emotionally I'm like, I don't know. I don't know if I want to put him through this again.
Oh, I get it. Every day I get that.
Harder in the
I mean,
long
that's
term.
awesome that you got it in before 3. That's amazing. Send me a picture of him later with it.
I will. He's so cute. I took a bunch of videos. I'll post some content on it on Instagram. So
I love
that's like,
it.
yeah.
Was there anything else we should cover before we wrap it up today? I mean, I know you and I could sit and chat for hours and hours.
I don't know. I think that's it. I mean, yeah. Yeah, I could definitely talk for hours
I
about all
just
this
think
stuff.
it's so refreshing and inspiring, and energizing to be around somebody like you that is root cause minded and truly at the base of every decision you make is for the parents and the patients and the families. And I just think that that's so important that providers continue to come back to that grounding anchor because you're going to be forever successful. You're going to touch so many lives and you don't get sidetracked down a path that might not serve people. So thank you for doing what you do.
Yeah, of
I really
course.
appreciate it. You've been very
Thank you.
influential in my own career.
Oh, thank you. Likewise.
Yeah.
you and everyone else that I see like doing so much. I like just want to like help contribute to.
Well, let's just keep doing it together. We'll have a follow-up conversation down the road, and I want to hear how Landon's doing. Thank you for fitting me in your busy, busy day. I know you're juggling
Thanks
so many
for
things.
having me.
My pleasure.
Always appreciate a platform to like talk and help educate and help parents make
Do a great job with it. If you're, like I said before, if you're not already, go visit Dr. Tracy's Instagram. Handle is Dr. Tracy Tran.
Yeah, it's Dr. Tracy Tran. DrTracyTran.
Go follow her. She's a wonderful, wonderful follow on Instagram. I always learn something. Have a wonderful day. Enjoy that California sunshine. And I will see you soon, I hope.
Thanks for tuning in to the Untethered Airway podcast.
If today's episode helped you see things differently,
Please share it with someone who would benefit from hearing this. And don't forget to subscribe.
want to learn more about airway health or connect with our team?
Please visit our website, untetheredairwayhealthcenter.com, or follow us on Instagram @untetheredairway.
Until next time, bye.